All right. This is TJ. We're going to talk about Chapter 13, Patient Assessment. Just not going to waste any time. Just going to jump right into it. Set the stage for what we're going to talk about here. We're going to go over scene size up, what it is, how to do it, primary assessment, components of it, and how you can't go from one step in the assessment to the next without completing this. Secondary assessment for stable and unstable trauma patients and responsive, unresponsive medical patients, and also the reassessment of each one. So, all your decisions, all the interventions that you're going to do, everything that you have planned as far as the treatment goes for a patient, they're based on an accurate, thorough, in-depth patient assessment. The more information you have, the better the quality of the decision that you can make as far as the intervention and direction of assessment goes. So it not only dictates how you treat your patient, but it also dictates which direction you're going to go as far as your follow-up and your reassessment. So we'll talk about the assessment. It includes your scene size up, the primary assessment, secondary assessment, and the reassessment of those things included. Scene size up, it's constantly changing. It's something that you're constantly doing. You want to constantly be evaluating the scene for hazards, anything that can potentially hurt your patient, you, or your crew. You have operational and patient care aspects of this. Your patient care, you're looking for your scene size up. You're constantly looking for clues as of what's going on with your patient. You know, what are some things that would indicate the condition that your patient is in? What are some things that, could possibly be a threat to that patient? In your scene size up, you also figure out what the mechanism of injury or the nature of illness and determining the number of patients are. This is the very, very beginning of the patient assessment process, the very, very tip-top portion of your skill sheet when you look at it. And this was something that you would do with every patient that you ever respond to as far as an emergency, because this is one of the things that helps keep you and your patient safe. Let's take a look at the steps of your scene size up. Use standard precautions. Use the precautions that you would use for every patient regardless. And that includes your PPE, your personal protective equipment, using the safety shields for your eyes, the eye pro, possibly ear pro, the mask, the gown that you would potentially need, anything that you would use for a standard patient, especially gloves. You want to evaluate the scene hazards, make sure your scene is safe, and ensure that safety. You have to have a reasonable expectation of safety on your scene. If you don't have a reasonable expectation of safety on scene, you need to relay to the appropriate facility that it needs to be secured in order for you to enter. Figure out what the mechanism of injury or the nature of illness is. Knowing is half the battle. So if you have a mechanism of injury that could potentially further injure your patient or end up injuring you or your crew, you want to make sure that you identify that and take preventions and precautions in regards to it. Figure out how many patients you got on scene. If you've got a mass casualty incident, it's going to be hard to transport 30 patients off of a bus accident with one ambulance. So this brings us to ascertaining the need for what additional resources you're going to need. If you're in a situation where you have remote access to a road, you may have to call for a helicopter. That may help you locate the patient if, it's a phone call where they can't give you an exact address, or if you have, a patient that's stuck on a roof, you may be able to call for a fire department that has a ladder truck or some kind of apparatus that'll assist you in getting that patient down from that elevated position. Primary assessment is conducted on every patient you come in contact with. And the reason for this is because we're trying to figure out what the nature of the problem is. We're trying to manage whatever threats to life there are, whether there's interference in the circulation, the airway, or the breathing of the patient. And we need to establish the priorities for what our treatment and our priority transports. We want to make sure that we identify those early so that our patient doesn't deteriorate, the condition doesn't deteriorate to a point where we can't do anything for them. Let's take a quick look at the steps in the primary assessment. Number one, you want to form a general impression of your patient. You want to assess their level of consciousness. That's your AVPU score. Remember the AVPU for alert, verbal, painful, or unresponsive. We want to assess their airway. That should be airway. That is a typo in the PowerPoint there. Assess their airway, assess the breathing, assess their oxygenation, assess the circulation, and establish the patient priorities. Now, when you're doing your primary assessment and you find some kind of immediate life threats, we have to identify and treat that life threat immediately before we go on to the next portion of the primary assessment. So let's say in a trauma, we notice that there's major hemorrhage. Let's say we have a patient that has a possible open femur fracture secondary to a crush injury, and we have got blood spurting everywhere. We have got to address that bleeding immediately before we move on to the next step, because if he runs out of blood, he's going to die. So if we have extensive bleeding, we're going to address that, because if he dies, we don't have an airway and we don't have breathing, correct? So let's go ahead and identify that, get the treatment started before we move on to the next step. All right, we'll go into detail about the general impression of your patient. You want to figure out your general impression of the patient's condition just as you lay eyes on them and as you approach where the patient is at. You want to determine if they're stable or unstable. You also want to figure out what their chief complaint is, and the patient is normally, if they're responsive, probably the most reliable witness to the event that's going on, whether it be medical or trauma related. Take a good look around your environment. Your environment will give you clues as to what's going on to your patient. If you've got, a unresponsive patient and there's empty pill bottles laying next to the patient, that's a good indication of, might be an overdose, something of that nature. So always try to make, observations of the environment that your patient's found in. When you look at your patient, you want to try to estimate what their age is. This is kind of something that you'll pick up a little bit later on as you've been doing it in the field for a little bit. Sometimes you can be fooled. Some people age better than others. Some people age like fine wine. Some people age like milk. So sometimes it's kind of difficult to figure out a patient's age. Cosmetic surgery is one of the things that inhibits this. Also take note what the patient's sex is. Male patients experience symptoms different than female patients do. And some instances of cardiac problems, cardiac illnesses, females will actually present with abdominal and back pain rather than chest pain in the event of an MI. So we want to, really take into consideration what our demographics are. Determine whether the patient is a trauma or a medical patient. If the patient's a trauma or medical patient, we have, different priorities that we're looking at here. You also want to ask if the patient's able to answer, ask them what's going on. Ask them, why did you call 911 today? That's a very direct question that they can give you a very direct answer to. Also, you want to be on the lookout to be able to identify and manage the immediate life threats, because once we identify them, we have to intervene, correct? That way we can't move on to the next step unless we do something immediately. Okay, let's take a look at this patient here. Let's form our general impression when we're approaching the patient. So judging by the condition of the door and the condition of the floors and everything, this is a well-kept and well-maintained home. There's not a lot of clutter going around. The patient met us at the door, apparently, or this may be a bystander, we're not sure. You ask her, ma'am, did you call 911? If she says, yes, I'm the one that called, I'm the patient. She doesn't appear to be in any kind of distress. She's obviously alert because she got up. I'm not going to say oriented because we haven't asked any orientation questions yet, but she's obviously alert because she knew to get up and answer the door when there was, foot traffic at the door. So she doesn't really appear to be in any kind of acute distress. I'm not seeing any signs of shock, any cyanosis around the lips, things of that nature. So I'm able to draw a lot of information from just, laying eyes on the patient. Also, she would be a good candidate to ask, ma'am, what's your emergency today? Why did you call 911? She would probably be a really reliable witness to tell you what's going on. Let's take a look at this gentleman here. As we approach the patient, we see him. He looks to be seated in the tripod position with pursed lips. Very good indicators that we have respiratory distress going on. Also, if you look there on the table, there's a huge clue that there's a respiratory illness involved with an uncapped inhaler. So it may not be the root of the problem today, but he obviously has some kind of respiratory illness that he's seen a physician for due to he has a prescription for an inhaled medication. Okay. The next patient that we're looking at here is a trauma call. We have an injury to leg. Pretty good amount of blood there that we can see, a decent amount. He looks to be in an industrial area where there's some constructions, possibly some construction going on. He has a tool laying next to him, and looks that he has a possible laceration to his shirt and also to his leg. So with the clothing being torn around those two areas, and with the blood indicators, I'm looking for something sharp. That tool looks like it possibly could have done it. I'm not seeing any blood on the tool, but we're picking up clues from our environment. He appears to be awake, so he would be a good, reliable witness as to what happened if he hasn't gone into shock. I'm not seeing any cyanosis around the lips or there to the fingertips, so looks to be compensating. We could. Do you think that would be a life threat, losing that much blood? I mean, that would definitely be something that would catch my attention, and make sure if we have, a steadily growing pool of blood, that we address that injury so that we can proceed on in our primary assessment. Here, when you walk into the room here, appears to be bedtime for this patient, considering he's wearing pajamas. Possibly a medical condition, I'm not really sure. But you can't rule trauma out in this indication because, people don't normally lay on the floor when they have a nice, appears to be high-priced bed laying next to them. I wouldn't sleep on the floor if I had a high-priced bed like that. So patients are not in a position that you would normally find him in if he's responsive. So can't rule trauma out. He may have hurt himself when he fell. Trauma may have put him there. This could have been, possibly a home invasion. Somebody kind of assaulted this man from behind and put him down. Without, closer review, we wouldn't really be able to tell without closer examination if there's not any trauma involved in this situation. So we would consider C-spine and trauma precautions and performing a trauma assessment primarily before our medical. Give you a little introduction to the spinal motion restriction. This is the self-restriction aspect of it. The patient is instructed to align his head, neck, and umbilicus and not to move. So we're going to put the head, neck, and the belly button all in one line. That way we're keeping our spine, in line along the long axis. There's no evidence of any injury. We can place the patient on a stretcher. If you have evidence of injury or the patient's unreliable, like with an altered mental status, we want to go ahead and apply a cervical collar and place the patient on the stretcher. You can also place the patient on a backboard or a vacuum mattress, so a full body splint for transport. Sometimes we find patients in unusual environments or circumstances. I've found people in storm drains before, unknown how they got there. We don't know if they were possibly thrown in there or if they wandered down there on their own. They're very hard to categorize whether they're medical or trauma. So we always want to keep C-spine in the back of our minds when we're assessing patients that we find in unusual circumstances or in environments. Sometimes we have, patients such as dementia patients that, get away from the homestead from where they're normally at home or, from skilled nursing facilities and find their way out. And, you may find them in wooded areas where they're trying to take a shortcut that they believe exists or, walking down the highway. We've had patients escape from hospitals and altered mental status. I've actually, been to one at a Waffle House locally that, had no idea that he had been in the hospital, was sitting at the counter waiting on his hash browns with a hospital gown that opened to the rear. So, can't really figure out, what's going on. Did they have trauma that caused that altered mental status, or was the altered mental status the basis for our medical call? When we're performing assessments, we're basically doing, being a medical detective. There's really no other way to put it. We're looking for clues in patients that are unresponsive and also responsive patients, pretty much every patient that we encounter, for things that could clue us in as to a patient's history or condition. Like this patient here. This patient's chest, they opened up his shirt to put the 12-lead EKGs on, EKG electrodes on. And once they opened his shirt up, they saw what we call a zipper chest, which is the scar from open bypass or a coronary artery bypass graft. You can easily see these. Sometimes you'll see medication patches. When you expose the chest, you may see a pacemaker. A new growing trend now is medical tattoos. So you may see a clue to a patient's medical condition that's been tattooed on their body. We'll talk about, figuring out whether your patient has been injured or if they have an illness. If they're injured, penetrating trauma, it's a force, any force that pierces the skin and body tissues. Okay, so if you have, excuse me, if you have a force that's exerted on the patient's body and it causes a separation of skin that goes into a soft tissue underneath, technically that is penetrating trauma. Blunt trauma is caused by a force that impacts the body but doesn't penetrate it. So your skin is intact, but you may have, bruising, redness, signs of impact around the soft tissue. Your environment is going to offer you clues, that the patient's suffering from a medical problem. So, you can look around and figure out in your environment a lot of times what's going on with a medical patient. And looking at this here, what do you think? Medical, trauma? I'd say trauma. A lot of the positioning here that you'll see here, if you approach this patient from behind with not being able to see the front portion of this, there's a possibility we could have, kidney stone. He could be having ruptured appendix, anything regarding the abdomen due to the fetal position drawn up at the knees. But when we go around to the side, seeing that we're in the garage area and we see the blood, there's a possibility of some kind of industrial penetrating trauma. So we're looking at that that patient as a trauma patient now that we see signs of an injury. All right, as you're getting your general impression of your patient, figure out, looking at the clues here that you see, I would not categorize this patient as a trauma patient. I mean, there's always the possibility that they had a fall or some kind of traumatic event that happened to them, and they just, felt that the best place that they could be would be the bed. I would always consider C-spine there, but in the reality of it, he may just not feel that great. He may just feel under the weather and figured that he would crawl into bed and get some rest. Again, looking at some of the clues, I'm not seeing anything out of place in the room here, and he appears to be well tucked in with pillows stacked up behind his back. So it's a very good possibility this is just nothing simple, just a simple old medical call. All right, let's get to the next step. Figuring out the chief complaint, getting it from your patient. Chief complaint is why EMS is there. Why were you called? Why did you call? You can ask the question like I mentioned earlier. Why did you call 911 today? It's a very, very open, direct question that your patient can answer honestly. Don't assume what they originally said is the true chief complaint. I've been to, couldn't tell you how many calls that ended up being something completely different than what I was dispatched on. I remember being dispatched one time to a patient with chest pain. Upon arriving on scene, the patient definitely had chest pain because it had a bullet hole in it. That went from being a simple medical call to a complex trauma / attempted murder call. So, don't always assume what you're originally told is wrong with the patient is the real underlying problem there. Always investigate, do your own investigation there, and ask your patient if they're able to answer. Trauma patients, they may have an observable chief complaint. All that means is that you may be easily able to lay your eyes on what's going on with that patient. That bright red blood is a very good indicator of what your problem may be. It's very important, very, very important to try to get the chief complaint from the medical patient, because a lot of times with a medical problem, they won't have any outward signs of what's going on. Also, behavioral issues, you don't have anything that is outwardly showing unless it's behavior. Behavior will be your only indicator sometimes to a behavioral emergency. So as far as their outward signs, they would have nothing out of the ordinary. Okay. This is just a list of life threats that require immediate management if found while you're trying to, get your general impression. Compromised airway. You can have all different types of things in the airway. If you got blood in it, vomit, secretions, patients, unresponsive and unable to maintain their airway, so the tongue's flat back in the throat. They may have bone in there where, they've had a fracture to the face, broken teeth from an assault or a fall, or the other substances or objects. Patients sometimes put things in their mouth. Kids put things in their mouth all the time. That can become airway compromises. Obvious open wounds to the chest. They're always something that needs to be addressed immediately. Paradoxical movement of a segment of the chest, we call that a flailed chest, where, when you take an inhalation, when you inhale air into your chest expands. Well, with a paradoxical movement, when your chest expands, you'll have a segment that goes inward. And when you exhale, your chest contracts in and you'll have an outward segment, a portion that goes to the outside. Major bleeding, whether you have a steady flow or spurting. Steady flow is an indication of what? Venous bleeding. Spurting would be an indication of arterial, correct? So any major bleeding, exuberant amounts, we want to go ahead and they all require immediate management to really jump on it and get ahead of the curve there. If the patient's unresponsive, not breathing, or their breathing is abnormal, agonal or gasping breaths, that's something that we need to correct immediately. So during our general impression, we're also scanning for immediate life threats. We have to, if the patient's in cardiac arrest, we have to recognize that immediately. So if the patient's cardiac arrest, first thing we're going to do, is we've recognized it because the patient's not breathing and they have no circulatory exertion. So what we want to do is immediately begin chest compressions, get that airway open, get some ventilations going, and apply the AED. That way, if that patient's in a rhythm that's able to be defibrillated, we want to get that done just as soon as possible. Next step we're going to do, if you suspect any kind of spinal injury, we want to go ahead and establish manual inline stabilization. Now that doesn't mean put a collar on them. That means you actually put your hands on the patient. Place one hand on each side of the patient's head, bring the head into an inline position, and place the head in the neutral position. All right, so we're trying to keep that cervical spine in line to reduce further injury. If the patient's alert, then we can use the self-restriction procedure. As far as the spine motion restriction goes, we can tell the patient to bring their head and neck in line with their belly button and the umbilicus. Tell them to keep their toes in line with the nose and navel, and instruct the patient to not move their head or neck until given further instruction. A lot of times your patient will try to nod yes or no if they're hurting because they're unable to speak. Encourage them to use verbal cues and use words instead of nodding their head yes or no, because this can complicate a spinal injury if they move their head or neck around too much. And positioning the patient for assessment if you suspect trauma. Log roll the patient after you quickly check the posterior of the body. When you're checking the posterior of the body, we're looking for major bleeding. Also, we're palpating and checking for any signs of step off, any signs of any kind of trauma to the back and to the buttocks. Things that are going to make contact with the board that aren't movable. Arms and legs we can assess without having to log roll the patient, because we can bend the patient's lower extremities at the hip and at the knee without compromising the spine. But in order to really get a good assessment of the spine, you will have to roll the patient, log roll them over to check the posterior. And if you suspect the spinal injury is possible, use that inline stabilization when you do such. Talk about mental status of your patient really quick. Level of responsiveness is really good indicator of improvement or deterioration in your patient. So we want to quickly assess the level of responsiveness during the AVP mnemonic. Are their eyes open? What's going on? We want to determine if they're alert to verbal stimuli, if they're alert to painful stimuli, or if they're unresponsive. So we're going to use that AVP mnemonic there. Alertness and orientation. If they're open, if the eyes are open, and they can speak as you approach them, you would assume that the patient is alert. The patient can be alert, but they can also be very agitated, confused, or disoriented. So alert and oriented cannot be used interchangeably. And this is just what I was talking about earlier. The AVP score, A stands for alert. Are they alert, able to talk, communicate? Are they communicating appropriately? V responds to verbal stimulus. If the patient responds to you when you hey, are you okay? Can you talk to me? Can you wake up for me? If the patient's unresponsive other than that, we're going to give them a V score. If you try to cue the patient and get them to respond to you with the verbal stimulus and it doesn't work, we're going to go to the painful stimulus or tactile stimulus, and you can perform a sternum rub, things of that nature in order to get a response from the patient If they respond to the painful stimulus, a lot of times when they've gotten to this point in their mental status, these patients will merely groan or withdraw from the pain. They're not going to really, give you many answers at this point of the mental status scale there. But if a patient is unresponsive, we've tried everything. We've, no spontaneous eye opening, they're not responsive to verbal stimuli, and they're not responsive to painful stimuli. So that patient is considered to be unresponsive. Okay, if your patient is responsive to verbal stimuli, they open their eyes, they respond or attempt to respond to your voice. If they don't speak, see if he'll follow a command, like raise your hand or wiggle your toes. If the patient obeys the commands, you can assume he has a higher level of responsiveness than the patient who stares off, talks inappropriately, mumbles, or does nothing at all. If there's no response when you talk to the patient, try a painful stimuli. Painful stimuli is just that. You apply pain to the patient to determine whether or how they respond. You can apply it centrally or peripherally. And I'm going to give you some examples of that. Methods for applying painful stimuli, they include the trapezius or armpit pinch, supraorbital pressure, a sternal rub or earlobe pinch, applying pressure to the nail bed, or pinching the webbing between the thumb and the index finger. A lot of times these methods will yield you a result for a patient that's responsive to painful stimulus. Responsiveness to painful stimuli, it's normally typically purposeful or non-purposeful. Movement towards the painful stimulus as if to push it away is noted as purposeful, but movement away from the stimulus would be withdrawn from pain. Flexion and extension posturing are abnormal responses. In flexion posturing, also known as decorticate posturing, the patient arches the back and flexes the arms inward towards the chest. In the extension posturing, also known as decebrate posturing, the patient arches the back and extends the arms straight out parallel to the body. Both are signs of very serious head injury. Here's a good example of what decorticate or flexion posturing. I always remember this when I was in MT school as the flexion decorticate. When you flex your muscles, that's decorticate. Decorticate is flexion. So the muscles are flexing. The next slide is going to show you a good example of decebrate posturing. So decebrate extension to where the back is arched and the arms are extended out. The lower extremities, as you notice too, everything is extended out. It looks like the patient's stretching to yawn. So that's how I remember that, was extension was stretching, decebrate. Extension posturing is produced when the lower portion of the brainstem is compressed. And just going back real quick to look at this flexion posturing, it's associated with compression of the brain at the upper portion of the brainstem. So we were talking about the painful stimulus and some of the problems with some types of painful stimuli. We always want to assess a central painful stimulus. The peripheral stimuli may reach the spinal cord but not the brain. And what I mean by that is the spinal cord can actually take an impulse and turn it immediately around and send it back to the muscle to move. So, you have a painful stimulus to the muscle, it sends it to the spinal cord to shoot it up to the brain. The spinal cord may say, ow, and turn the impulse around and tell the muscle, hey, get out of there. So the impulse never really makes it all the way up to the brain, so it's not the brain telling the muscle to move, but the spinal cord's just reversing the impulse and sending it back out. Okay, unresponsive patients, the patient that does not respond to verbal or painful stimuli is considered unresponsive. These are high priority patients due to the fact that we don't know what made them unresponsive, and we're not really sure what made them that way, and they're not able to tell us a chief complaint. Unresponsive verbal and painful stimuli can tell you that either the patient's not able to maintain their own airway. They're considered to have altered mental status. They're not completely unresponsive. If they're not completely unresponsive, they're considered verbal or painful, but that is still considered altered mental status. Any deviation from normal is considered altered. But even those patients with verbal and painful stimulus level of consciousness can be prone to airway compromise. A patient's level of responsiveness is one of the first things that you really want to document. That's one of the first outward signs that you can see in a patient's assessment. You want to be very specific, and when you document, that way you establish the baseline to what your assessment findings will be later on, especially after you perform interventions. AFPU checks perform very quickly, and we want to establish that baseline. It shouldn't take you more than a few seconds to accomplish this. Don't waste time doing extensive neurologic exam during your primary assessment. This is to identify live threats and a way to correct them and figure out our general impressions. So we're not going to do anything in detail initially. Next thing we want to talk about is assessing the airway. All right, we're going to figure out what our airway status is. Occluded airway is an immediate threat to life because without an airway, we don't have breathing, right? So patient who's alert and talking without signs of distress has a patent airway. If you have a patient, a lot of times the old adage of a patient that's standing there talking to you smoking a cigarette that says, "I can't breathe." Well, I kind of have a hard time believing that sometimes, especially if they're puffing on a cigarette and they have a good patent airway talking to me, and I can watch symmetrical chest expansion, things of that nature. So the patient who's alert and talking without signs of distress, their airway's patent. The mental status check is also a very helpful tool for simultaneously gathering information about the airway status, because if you go into a patient's home or up to a patient out in public, wherever the call may be, introduce yourself and ask them questions, they're able to respond appropriately, using verbiage. If they're talking to you and able to answer your questions without any difficulty, and you're not noticing any elevated work of breathing or anything like that, you've just simultaneously assess the airway and also the mental status. Okay, and the responsive patients that you respond to, you can look at airway compromise indications such as audible stridor, problems speaking. If the patient's speaking in short, choppy sentences, that's a really good indicator that there's some kind of airway problem going on. If they're gasping for breath or not speaking, if they're not speaking, they're concentrating on breathing a lot of times. If they're alert and talking without difficulty, or if an infant or child is crying, you can assume airway is patent and move on to the assessment of the breathing. But an obstructed airway is immediately life-threatening problem. So one of these things that's going on that you see here, it would be something that you want to address immediately. In many patients, figuring out the level of consciousness and figuring out the status of the airway, as I mentioned earlier, they pretty much go hand in hand and occur simultaneously. The patient who's awake, oriented, and alert and speaking to you without difficulty, that's an open airway. But they can be alert and still have a partially obstructed airway. In the unresponsive or severely altered mental status patient, you have a very, very high risk of airway compromise. You must take action to open or maintain that airway. If they have a severely impaired level of consciousness, you can use a lot of different methods to open the airway, and they'll be used and needed, including the manual maneuvers, suctioning the airway, using airway adjuncts, and methods for opening the airway and relieving a foreign body that's creating the obstruction. So on a trauma patient, we're going to use a jaw thrust maneuver, correct? If we're suspecting any kind of spinal trauma, we're going to use a jaw thrust. But for medical patients, we use head tilt, chin lift. Most common airway obstruction is going to be the tongue. Muscle relaxation in these patients that are unresponsive allows the tongue and epiglottis to fall back and partially block the lower part of the pharynx and the opening of the trachea, so air can't pass in and out. Well, it kind of creates a larger flap. When you go to take a breath in, the tongue flaps backwards and basically covers the hole, so you're not able to get any air down to where it should go. If the patient's not talking to you, or they're not responding normally, or they have a severely altered mental status or unresponsive, we have to assume that airway is closed or may become closed. So talk about some techniques to use. We can use manual airway maneuvers. That prevents the tongue and the epiglottis from blocking the airway. We'll use the head tilt, chin lift maneuver, the jaw thrust. We can also use suction or finger sweeps. That removes blood, vomit, food, secretions, foreign objects, anything that's in the airway that shouldn't be there. we can normally get out with suction. Airway adjuncts, covered OPAs and NPAs help us maintain the patent airway. Even if the tongue does flat back, an NPA can go back far enough down into the pharynx to get below the tongue into the pharynx to where we can ventilate that patient efficiently. Manual thrust for the abdomen. For infants, a combination of chest thrusts and back blows force bursts of air from the lungs to expel an object. The abdominal thrusts are used in the adult, and that helps relieve the blockage of airways by foreign bodies. We want to also look at positioning the patient. Sometimes positioning a medical patient that has no suspicion of spinal injury, we want to put them in a modified lateral position to allow secretions, blood, or vomit to flow out of the mouth instead of into the airway. So if we roll them onto their side in the lateral position, we're actually using gravity to our advantage, where secretions and vomit will actually flow out of the mouth instead of backwards into the airway. When you go to assess the airway and you hear snoring, if you hear that, it's an indication the tongue and likely the epiglottis are partially blocking the airway. So we're going to use our head tilt chin lift maneuver in medical patients and the jaw thrust in our trauma patients if we suspect spinal injury to relieve the airway of any obstruction that can be caused by the tongue or epiglottis. The patient starts to gag when we start using adjuncts. We want to remove that immediately and be ready to suction and consider insertion of the nasopharyngeal airway. On your initial approach to the patient, you can sometimes hear abnormal sounds coming from the upper airways. So these will be audible without actually putting a stethoscope to the patient's chest. These sounds are a good indication that the airway may be partially blocked. If they're snoring or sonorous, it's a rough snoring type sound on inspiration and or exhalation. Gurgling, it's a sound similar to air rushing through water on inspiration or exhalation, normally indicative of vomit or secretions in the airway. Crowing, a sound like a calling crow on inspiration, and stridor. It's a very harsh, high-pitched sound when the patient takes a breath in. So if we hear gurgling in a patient, what we want to do is immediately open the mouth and suction out the contents. If the contents are too thick to be suctioned out, let's get that patient on their side and sweep the mouth out with your fingers, a tongue blade, or the suction catheter itself. That way we can get that airway opened up and do our best to begin our management. And speaking of crowing and stridor, crow and stridor, they're high-pitched inspiratory sounds. They indicate swelling or muscle spasm of the airway. Manual airway maneuvers will not relieve this obstruction. Don't ever put anything into the airway of a pediatric patient with crowing or stridor. If you put anything into the mouth of a pediatric patient with crowing or stridor, other than an adjunct, a suction tip, a tongue blade, or fingers, anything that you're trying to do that way, it can actually cause extremely dangerous airway spasms and eventually a complete airway obstruction if it spasms and that tissue becomes inflamed. So since we covered airway, we're going to talk about breathing next. After we get the airway open, we want to determine whether the patient's breathing inadequate or adequately. So, excuse me. If the patient's breathing adequately after our correction, we can move on to the next step. But if we're not breathing adequately or inadequately, we want to figure out if the patient needs oxygen therapy or if we need to possibly help them breathe. Patient doesn't have adequate tidal volume, or we're not hearing breath sounds in all four quadrants. We possibly want to provide positive pressure ventilation with supplemental oxygen. So when we're checking for breathing, techniques we're going to use are looking, listening, and feeling, using our senses. So we want to check rate and quality. They both have to be adequate, to be considered adequate breathing. We want to look for signs that the work of breathing has increased, such as, use of accessory muscles. If we're suspicious that our patient is not being oxygenated adequately, what are some signs that, we can look for outwardly that would indicate that our patient's not receiving enough oxygen? If the patient's hypoxic, there's a good sign that you could start seeing, number one, altered mental status, and then we just want to start looking at the tissues peripheral tissues for cyanosis, such as around the lips and gums, fingertips. We want to see if that patient's starting to turn blue. And when they turn blue, that term is called cyanosis. Here's some of the things we want to look for. We're looking for inadequate tidal volume, an abnormal respiratory rate, bradypnea, which is a slow respiratory rate, or tachypnea, which is a fast breathing rate. Poor movement of the chest wall indicates that you have not the adequate amount of air being breathed in with each respiration, and that's typically described as shallow respirations. A respiratory rate that's too slow, called bradypnea, causes inadequate minute volume, and you'll refer back to what minute volume is. It's the amount of oxygen or amount of air that is breathed in over 1 minute. The respiratory rate that's too fast, tachypnea, may not always result in better breathing status for the patient. When the rate gets too high, the lungs don't have enough time between breaths to fill adequately. Therefore, your minute volume again becomes inadequate. Here's some other outward signs that we're looking for as far as breathing goes. We're looking for retractions. This identifies the tissues have a sunken in appearance. Every time the patient takes a breath in, those tissues are pulled inward. Also, use of accessory muscles on nasal flaring. The nostrils flare out as the patient exhales. They try to get bigger to increase the volume. Tracheal tugging. It's a pendulum motion of the trachea and the anterior neck when the patient inhales. Pale, cool, clammy skin. It's a very, very ominous sign of poor perfusion and that the cells and tissues aren't, getting the oxygenation that they need. Cyanosis. It's a bluish or blue-gray tone of the skin around the lips, nose, fingernail beds. It's also a very good indicator the patient's not getting good oxygenation. Pulse oximetry, less than 94%. That's pretty self-explanatory. If the pulse ox is less than 94, that's a latent sign that the patient is hypoxic. The chest wall moving asymmetrically. A chest wall should move symmetrically. Both sides move at the same time and very smoothly. Unequal movement, one side moving up and outward as the other moves down and inward, that's asymmetrical. So that pretty much covers everything that you're looking for as far as the breathing goes. Let's go to the listen and feel section. We're going to listen for air movement and feel for the escape of warm humidified air. So I'm listening for air, the sound of air moving in and out through the nose and mouth, and feeling if I feel warm breath. If they're not breathing or they're breathing inadequately, you must immediately begin positive pressure ventilation with oxygen. Any delay in treatment, you're looking at possibly a lead to brain death and cardiac arrest. Patient doesn't have adequate tidal volume, adequate oxygenation, or they have other signs of respiratory distress, we really need to be identifying that very quickly and starting interventions. If the chest is rising and falling adequately, you hear and feel good air exchange, and the respiratory rate is adequate, but there's no evidence of any serious respiratory distress, assume that the patient's breathing is adequate. If the patient with adequate breathing is responsive, but you determine is ill or injured, we can consider giving them oxygen. Looking into the assessment of whether the patient's oxygenating appropriately or not, we're looking for hypoxia or hypoxemia, signs of poor perfusion, signs of heart failure, and signs of respiratory distress. Pulse oximeter should be applied very early in the assessment process to determine, if the patient is oxygenating adequately. Okay, moving on to assessment of the circulatory system. In the ABCs, this is the C. When you go to assess the circulation in your primary assessment, you need to do it in these steps. One, let's check and see if they have a pulse or not. Secondly, let's check and see if they have any kind of possible major bleeding going on, whether it be pooling or spurting. Let's check the skin color, temperature, and condition, and assess the capillary refill. The main purpose for checking circulation is to determine whether or not the patient's heart is beating, whether or not they have any severe bleeding, and whether blood is circulating adequately. So this is not a very detailed thing. We just want to make sure that they have a pulse and see if we have any kind of signs of shock, any signs of trauma or injury. When you're checking the pulse, you want to quickly determine whether it's present or not. Determine the approximate heart rate, beats per minute, and the pulse's regularity and strength. Elderly patients commonly have irregular heart rhythms, that is, and an abnormal rhythm that has no real pattern. In many elderly patients, this kind of abnormality is normal for them. However, it's also very important to report and document this finding because it can be related to the current condition that they're experiencing, to the emergency that you're there for. So your normal heart rate, sometimes they're less than 60 per minute or greater than 100 per minute. You want to make sure that you note any heart rates that are less than 60 or greater than 100. Bradycardia, which is a heart rate less than 60, can indicate severe hypoxia, head injury, drug overdose, heart attack, or some other medical condition. Heart rate greater than 100 per minute may indicate anxiety, blood loss, shock, abnormal heart rhythms, heart attack, drug overdose, early hypoxia, fever, and other medical or traumatic concerns. We've identified some major bleeding. If we notice, there's large pools of blood or the clothing's blood soaked, we need to immediately expose where we notice that blood at. And we want to make note, is it bright red? Is it spurting? That can indicate an arterial injury. Or if it's dark red, steady, and rapid, that could be a large venous vessel. If either of these types of major bleeding are present, immediately place gloved fingers or a gloved hand on the wound and put direct pressure to control the bleeding. Put a pressure dressing once the bleeding has been controlled. Do not waste time with slow oozing capillary bleeding or other wounds that do not present with major bleeding during the primary assessment. We are looking for major bleeding here, not small, superficial lacerations. I want interventions done on major bleeds. The patient's perfusion status can be assessed by checking the patient's skin, as easy as it sounds. What color does it look like? Does it feel cool and clammy, or is it normal? What the temperature of it is, and what the condition is. Capillary refill alone cannot give you an accurate assessment of perfusion in infants, children, or adults. You have to also look at the mental status, the heart rate, what the peripheral and central pulses feel like, skin signs, and blood pressure to determine the perfusion status of the patient. Hemoglobin and red blood cells changes color when it's starved of oxygen, thus giving the skin of a hypoxic patient its bluish cyanotic tint. So when we're checking skin color, we want to look at the mucous membranes. Make note if they're pale or mottled. That can indicate your decreased perfusion and shock. If they're cyanotic, like I mentioned, it's an indication of decreased oxygenation to the tissues. If they're red or flush, the vessels have dilated, and if they're yellow, we have a liver dysfunction there. These are all things you want to note in your assessment. Looking at skin temperature, if the skin is hot, more likely the patient's been in a hot environment or they have an elevated temperature. Something has made that patient's temperature elevate, whether it be the environment or something metabolic. If they're cool, you could be in a cold environment, decreased perfusion, all indications of blood not being in the tissue. If it's cold to the touch, you could have frostbite, hypothermia, or even death when blood isn't circulated through the tissue. That warm blood doesn't carry through to the tissue to give a cold feel to it. Cool and clammy, shocked, nervous, they're frightened. If you can't feel the temperature through your glove, you may need to slip your glove down and place the back of your hand or fingers on the patient's abdomen, face, or neck. Skin should normally be warm to the touch, but may instead feel like one of these that I mentioned. Condition of the skin is a good indicator as well. If the skin is dry, the patient can be suffering from dehydration, from heat stroke, spinal shock, or a multitude of other medical conditions. If it's moist, is it a humid environment? Has the patient been exercising, exerting themselves? Patient could be in shock or have some other medical conditions. Some medications can actually make a patient sweat. Moisture clammy scans associated with medical or trauma conditions is typically produced from circulating epinephrine. Epi stimulates alpha receptors that cause the sweat glands to produce and secrete sweat. Talking about capillary refill, definitely more reliable in infants and children. It's most reliable at room temperature, so if you're out in the environment, in colder temperatures or hotter temperatures, you're not really going to get the reliable results that you normally would at room temperature. Using this alone, it does not give you an accurate perfusion assessment. You have to use this in conjunction with other methods. If capillary refill takes longer than 2 seconds in infant, child, or adult males at room temperature, tissue perfusion may be inadequate. The upper limit for adult females is 3 seconds, and for elderly is 4 seconds. Talking about shock, shock is a very life-threatening condition, and treatment needs to begin immediately during the primary assessment. If you have a significant mechanism of injury, altered mental status, severe bleeding, assume that patient is in shock. Control anything seriously bleeding that you can. If possible, splint any bone or joint injuries, but only if it does not delay transport. Do not ever delay transport to splint bones or joints. I have seen people splint people to death before. Provide positive pressure ventilation with supplemental oxygen if needed, or oxygen at 15 liters by a non-rebreather. Keep them warm, and these patients are always immediate transports with assessment. Get them to definitive care as quickly as possible. Okay, in the primary assessment, you want to identify, manage any of the life-threatening conditions immediately. Don't waste time. If you see something, go ahead and address it. Any critical finding of the airway, breathing, oxygenation, or circulation, that categorizes that patient as unstable. And unstable patients are always high priorities for treatment transport. When you start forming this general impression and you have, assessed the airway, breathing, oxygenation, circulation, you need to figure out, are they a priority for transport and a priority for rapid secondary assessment? These patients that have any kind of issues with this primary assessment, if you find anything that puts a doubt in your mind, you need to establish that this patient is unstable and needs to be transported immediately. So the priority decision that you make at the conclusion of your primary assessment, that's going to dictate when and where the remainder of the assessment treatment is going to occur. Whether you're going to treat and reassess on scene or do it on the way to the hospital. So like I said, at the very beginning of the lecture, your primary assessment is going to set the pace for the entire patient encounter. Things that, are going to require rapid transport. It's going to be, you have a poor general impression of the patient's mental status, they're unresponsive or altered. They responsive, but they can't obey commands. They can't establish or maintain an airway. They have difficulty breathing, respiratory distress, absent and adequate breathing. They don't have a pulse. Uncontrolled hemorrhage, severe blood loss. Skin is pale, cool, and clammy. You suspect they have shock. Open chest wounds, flail segments. They have severe chest pain with, systolic BP of less than 100. Severe pain everywhere or anywhere. Childbirth, complicated. Childbirth is classified as complicated if it's anything other than normal. If the body temperature is greater than 104, while they're showing signs of hypothermia, severe allergic reactions, and poisoning or overdose of something that you don't know and don't have an antidote for. Unstable patients are always, treated and reassessed during transport because they're priority patients. We need to get them transported as soon as possible. While stable patients, you can assess further and treat at the scene and slightly, delay transport because that patient is considered stable. So since we covered the primary assessment and, how we can't move on from the primary assessment until we've identified and treated all our life threats. Let's move on now to our secondary assessment. It's performed after the primary, and we identify any additional injuries or conditions that's going on outside of our airway, breathing, circulation, oxygenation, and shock assessment. So the approach to secondary assessment differs according whether the patient has a medical problem or they're a trauma patient, and whether the patient has a minor or a serious complaint. So our secondary assessment looks a lot different than our primary. This is where we actually do our physical exam more in depth, and also our baseline vital signs, and try our best to obtain a patient history, any problems that the patient may have had prior to the EMS encounter. You want to tailor your assessment to your patient. Each patient gets an assessment tailored specifically to them, and also it's individual to the suspected condition or injury. The secondary assessment is going to kind of differ from the primary in that the steps will vary according to the nature of the patient's problem and the seriousness of the condition. So your physical examination, we're going to use techniques to include inspection, using your eyes to look at affected body systems and body parts, palpation, actually putting your hands on the patient and touching them to sometimes elicit a pain response, and rule out if there's any pain to you touching the patient, and auscultation, which is where you actually put a stethoscope to the patient and listen to certain portions of the body. It helps us identify signs and symptoms. An anatomical approach proceeds from head to feet, so we want to start from the head and work our way down. When you're doing a secondary assessment on a stable, non-critical trauma patient, injuries can be managed as they're found. So, we've done our primary assessment, and now we're in our secondary assessment phase. Once we start finding these injuries, we can start treating them as we find them. Any clothing that interferes with your ability to properly inspect and examine a trauma patient should be removed, cut off the anterior part, and allowed to fall away. So cut from the front and just let it flat back. So going back to the anatomic approach for secondary assessment, you want to do it systematically, starting at the head and moving down to the feet. Rapid secondary assessment is performed on unstable or critical medical or trauma patients. So you have one that kind of takes its time, and a secondary assessment that kind of delves a little bit deeper in depth, and then you have the secondary assessment for unstable and critical medical trauma patients that is a lot more rapid. Use the same techniques, but the approach is abbreviated in the rapid secondary assessment to rapidly find potential life threats that could have been underlying. The rapid secondary assessment may not use all of the techniques that you'll learn. We use a mnemonic called DCAP-BTLS in the secondary assessment. And using the anatomic approach, when we assess the head, we're inspecting the head and scalp for any deformities, contusions, abrasions, punctures, burns, lacerations, swelling, and tenderness. You want to assess the eyes, ears, nose, and mouth. Moving on down from the head, we go to the neck. We're looking for signs of injury. We want to cover any open wounds. We're looking for jugular vein distension and palpating for tracheal deviations. So what would be something significant during assessment of the neck? Be thinking of that. If you got a gaping hole with blood spurting out, you got some major vessels that run in the neck, that would be a cause for concern. Tracheal deviation can be a sign of something that's going on in the chest. So, but we can't see. So tracheal deviation in the neck would be something very, very important to look at. Also, jugular vein distension could be something going on cardiovascularly, and also another indication of something going on with the chest. So the neck is a very good indicator of signs and symptoms of something that's going on that we haven't gotten to yet. Moving down below the neck, we go to assess the chest. We want to inspect and cover any open wounds. We're looking for paradoxical movement, a flail segment, immediately life-threatening condition. A patient with a simple rib fracture may breathe very shallowly and rapidly because of the pain associated with deeper breathing. And by intentionally breathing shallow, the patient is lowering their tidal volume and having, inadequate ventilation. This can lead to the patient becoming hypoxic, particularly in the elderly patients and those that have underlying lung disease. We want to palpate the chest as well and listen to breath sounds. Very good indicators for something that we can catch and address early on. All right. Moving to our systematic approach, our anatomic approach of the secondary assessment under the chest, the abdomen. Want to inspect and palpate all four quadrants and laterally. We're looking for distension and discoloration of the abdomen. We want to avoid palpation of pulsating masses. Anything that has a mass that has a pulse in it could be an indication of a possible AAA. That's bad news if you start putting a lot of pressure on it. We're checking for signs of peritonitis. A patient that has severe abdominal pain a lot of times lies extremely still, and they draw their knees up towards their chest and breathe fast and shallowly to reduce the movement of the diaphragm. So less movement, less pain. Condition sometimes involves irritation of the peritoneum, which is the lining of the abdomen. Patients complaining of pain but feels better if they're up and walking can actually be suffering from a bowel obstruction. Here's a good assessment technique called a heel drop test. The heel drop test is performed by having the patient stand on the balls of their feet, so they're standing up on their tiptoes, and then they suddenly lower their height by dropping suddenly onto the heels. If they have pain in the abdomen, this is a positive for rebound tenderness, and it's an indication of peritonitis or other inflammation within the abdomen, such as appendicitis. The heel jar test is performed by striking the bottom of the heel forcefully with the fist. Performing a heel jar test if the patient is supine or unable to stand when you are assessing the lower extremities. You want to make a fist and strike the bottom of the heel forcefully enough to jar the abdomen. Don't tell the patient that you're doing what you're testing for, and watch if they grimace or react in pain when you do this. This will give a good indication of peritonitis. And it's also a very good field test to check for appendicitis. All right, moving down below the abdomen, we have the pelvis. Injuries to the pelvis can be very critical. You don't want to palpate if you have obvious fractures, obvious injuries to them. Priapism can indicate a spinal injury. If the patient has no pain in the pelvic region or is unresponsive, nothing obvious going on, you want to place each hand on the anterior lateral wings of the pelvis and gently compress inward and downward. So you want to put your hands on the wings of the pelvis, push inward, your palms towards each other, and then push downward towards the floor. If you feel any crepitus or any rock, any abnormal movement, you want to note that, and that needs to be secured. Priapism, of course, is the erection in the male adult. That can indicate a spinal injury. You just want to check for that with the back of a gloved hand. Just run it down the anterior portion of the patient's body and check to see if that's present. And just here's an example of how to assess a pelvis. A patient who's unresponsive or who doesn't know any pain in that area. Don't rock the pelvis or apply any unnecessary pressure. You're assessing for instability, tenderness, or crepitation. You want to place the base of your hand on the symphysis pubis, the pubic bone, located immediately above the genitalia, and apply gentle pressure backward, checking for tenderness, crepitation, and instability. All right, moving down from the pelvis, we want to assess our lower extremities. So we're looking for signs of injury and edema. We're going to check for signs of deep vein thrombosis, or abbreviated as DVT. We're checking pulse, motor function, and sensation. So we want to look for deformities, contusions, abrasions, punctures, burns, lacerations, and swelling, and watch for abnormal positioning, because injuries to the hip or femur may cause the leg to shorten or rotate inward or outward. In the medical patient, we want to also look for excessive swelling around the ankles, which is what we call peripheral edema. This could be an indication of possible cardiac failure, especially in right-sided heart failure. In medical patients, we want to check for pain in the calf during dorsiflexion and plantar flexion. What we're checking for here, it can also be an indication of deep vein thrombosis if they have pain upon these movements. And it's a very significant finding in a patient that's complaining of shortness of breath or fainting or syncope. These patients have passed out or have had shortness of breath and they have a history of deep vein thrombosis. Or they've had these symptoms and don't know that they have deep vein thrombosis. If you have a finding when you do these tests, it's a good indicator that we possibly have a pulmonary embolism, which can be fatal. And then we want to move to the upper extremities. We're looking for signs of injury. We want to check the pulses in both arms, check the motor function, sensation, perform a stroke assessment, and check for arm drift. We want to inspect the upper extremities from the shoulder to the fingertips. We want to look for deformities, contusions, abrasions, punctures, burns, lacerations, swelling. On one side of the body, a patient may be able to move and feel light touch, but can feel no pain. On the opposite side, he may be able to feel pain, but is unable to feel light touch. Or perhaps he can't move on that side. These findings are consistent with spinal cord injury that is incomplete, where some nerve tracts are intact and some are not. So we call that an incomplete transection. This is very, very pertinent findings. So we know that there's a possibility that we have a spinal injury there. And then moving on, we want to look at the posterior portion of the patient's body. We want to inspect and palpate the area. Make sure you put your hands on it and your eyes on it. This includes the thorax, the lumbar area, the buttocks, and the lower extremities. If you suspect a spinal injury, spinal motion restriction always has to be maintained. So you want somebody, hold C-spine stabilization manually. When you're assessing the patient's back, you may note some muscle spasms along the vertebral column, along the spine. These spasms actually occur as a defensive mechanism of protective reflex to keep injured or fractured vertebrae stable and in line following an injury. So the body's actually trying to compensate to keep that spine in line so that we don't have any further injury. Okay, looking at the secondary assessment from the body systems approach, once you find a problem, consider all the body systems that can be affected. It's very important to link all the systems together, and that will help you also determine the severity of the condition and in turn your patient priority. The body systems approach will help you link findings from the complete head-to-toe exam that will provide information about the extent of that injury and the effects on the other systems. So, what was a patient that was stable and you were able to kind of stay and play a little bit, you do your secondary assessment. Now we've changed our priority if you find something there. Looking at the respiratory system, we want to evaluate the chest shape and the symmetry. Accessory muscle use, is it present, is it not, and the auscultation. What are our breath sounds? What do they sound like? Am I hearing anything abnormal? When we're conducting that head-to-toe exam, we have to identify the findings that are related to the body systems and make the links, make the connections there. That way we can, kind of get a lot better clue of what's going on, because we may have a much deeper problem than what we initially thought. Looking at the circulatory system, the cardiovascular system, peripheral and central pulses, are they present? Are they strong? Are they weak? And the blood pressure. Rate, rhythm, strength, and the location for your pulses is very important. Also, the systolic, diastolic, and pulse pressure for the BP is all indicative of a condition of our cardiovascular system. Looking at a patient and doing the neurological exam, we're looking at the patient's mental status. What's their AFPID score? Are they oriented? Their posture and motor activity, is their posture upright? Are they able to maintain a normal posture? The motor activity, are we looking at arm drift here? Do we have any signs and symptoms of stroke? Facial expression, is there any indication that we have some asymmetrical facial expression where the patient goes to smile and you have droop on one side? Their speech, does it sound slurred? Is it fast? Is it manic? Is it loud? Their mood. Are they anxious? Do they appear to be preoccupied with something? Do they seem to be calculating? And their memory, perceptions, are they able to recall events that happened prior to the event that called EMS out there? What kind of mood is the patient in? What's their nature? How do they appear? Do they appear intense, upset about the situation? Do they appear suicidal? Do they have any thoughts and perceptions of the events that's going on there? Do they appear logical? Their thought processes, are they intact? Are they able to be organized? Or are they just all over the place? And their thoughts, the content of the thoughts that they're having, they have unusual thoughts? Are they unpleasant thoughts? And their perceptions, are they hearing things? Are they having auditory hallucinations, visual hallucinations, or having just extremely unusual perceptions of things? That's all included in your neuro exam. And we're checking facial symmetry here. Just ask your patient, say, let me see you give me a big grin. I want to see that beautiful smile. When you do that, you're able to check for facial symmetry. It's movement of the facial muscles. So you're able to assess, appropriately if the patient has any weakness one side or the other. You're also using the patient's body language by their facial expression. You can tell a lot by a patient's facial expression. Do they appear anxious? Do they appear depressed? Do they appear angry? Do they appear scared, sad? Do they look like they're in pain? Or like we were assessing for the stroke, is the face symmetric or does it have any droop to it? These are all things you can assess by just taking a quick look at your patient's face. When we're assessing the musculoskeletal system, we want to look at the pelvis, the lower extremities, the upper extremities, what the status of perfusion is to those extremities, and what the posterior of the body looks like. And we're checking for symmetry, tenderness, range of motion. Any abnormal range of motion would be a sign. It could be a pre-existing medical condition, but could also be an indication of injury. Distal pulses, are they present? If I'm checking distal pulses and I don't feel any, and that's a good indication if my patient is awake that our blood pressure, we're starting to have some signs of hypoperfusion due to distal pulses not being present. In conjunction, of course, with skin color and temperature, and we also want to assess our sensory and motor function in these extremities to make sure that our neurologic impulses are intact and communicating with the extremity from the central nervous system. When we assess vital signs, sometimes this is going to occur at different times in the assessment depending on what kind of patient you're dealing with. Are you dealing with trauma or medical? The patient's responsive or unresponsive, and the patient's stable or unstable. So when we do assess vital signs, we definitely want to get a breathing rate and note if the tidal volume is adequate or not. When we get a pulse, we're looking for where we got the pulse at, what rate was our pulse, what strength was it, and was it regular. We're checking our skin for skin temperature, color, and condition, and our cap refill. Capillary refill, of course, I gave you the figures for that earlier. Less than 2 seconds. Adult females would be less than 3, and elderly would be 4 seconds. The blood pressure, we want to check a systolic and diastolic. Some patients, in the environment that you'll be in, you won't be able to get a good audible blood pressure. Get an audible one if you can, at all possible. That way, the more data you have, the better off you can make a decision. So you may have to palpate a blood pressure. We want to also check the pupils. We want to make sure that pupils are equal and symmetrical. We want to note the size of them and the rate of reactivity. Do they react immediately, or are they sluggish, or are they non-reactive? Those are all important things to indicate neurologic function. And then, of course, we want to get an SpO2 reading to ensure that our patient is oxygenating the way that they should. Let's talk about getting a history on our patients. You can use whatever approach or technique works for you if you collect the necessary information. The mnemonics that we give you, they tend to keep the EMT from doing a shotgun approach and getting a history from the patient, and they allow you to get the necessary information. So we've always used sample. Sample is a great mnemonic to use for a portion of the history. Sample, of course, being SAMPLE. The S stands for signs and symptoms, A for allergies, M for medications, P, past medical history, L, last oral intake, and E, events prior to this event. The OPQRST mnemonic is used to further evaluate, what the patient tells you is wrong and any other complaints that the patient may have. For example, if the patient complains of chest discomfort, shortness of breath, and nausea, the OPQRST mnemonic can be used to further investigate each of the complaints separately. So you would ask the patient, O for onset, P, provocation and palliation, what makes it better or worse? Q, quality, can you describe it to me? What does it feel like? R, radiation, does it go anywhere? Does the pain stay in one spot? Severity, scale of 1 to 10, 0 to 10, 0 being no pain at all, 10 being the worst pain you've ever had in your life. Can you tell me, give me a number value to your pain? And time, what time did this start? How long have you been hurting? Or how long have you been nauseated? Or how long have you been having chest pain? Okay, so the kind of physical exam you're going to conduct is based not only on the mechanism of injury, but also how much force caused the injury. Also, you want to go back to your findings in your primary assessment, take a look at those, and that way you can determine whether you can stay and play or whether you need to load and go. You need to always be reevaluating the mechanism of injury for your basis to figure out what your secondary assessment approach is going to be to a patient. So I've seen in my career several people who've been in accidents where the mechanism of injury was so great, just upon approach, you don't expect anybody to be alive, but for them to come out unscathed with relatively minor injuries. And I've also seen accidents, injury patterns, and mechanisms of injury that seemed insignificant, but you end up having either a fatality or a severe injury, severe head injury. So you need to constantly be reevaluating the amount of force that's used in addition to the mechanism of injury. So your MOI is actually directly related to the potential for critical injuries. You need to have a high suspicion when you have a significant mechanism of injury for underlying injuries that don't present immediately. The more significant or severe MOI, the greater the chance that you have for a severely critical or serious patient. Your emergency care is usually going to be based on the findings of a scene size up and a high index of suspicion. So if your gut's telling you that something's just not right with this patient, that something else is going on, follow your instincts. Here's just a few examples of significant MOIs. Ejection of the patient from a vehicle. If it has enough force to throw a patient from a vehicle, whether it be a motorcycle or passenger vehicle, it's a significant mechanism of injury and a significant force. Not only the initial impact through the windshield or off of the vehicle, but also upon landing, and you have secondary and tertiary impacts inside the body of the organs. Death of a person in the same vehicle as the patient. If you have a passenger in the same vehicle that sustained enough force that it actually ended their life, you can just about bet money on it that the person that's riding with them that was involved in the same accident in the same vehicle sustained the same amount of force that the fatality did. If a person falls from a height greater than 20 feet, that's typical injury that we see there is called axial loading, where you actually have burst fractures from everywhere from the heels of the feet all the way up to the cervical spine and anywhere and everywhere in between. Very significant with falls greater than 20 feet. Humans tend to try to land on their feet when it's never works out in their favor. Rollover in the patient's vehicle. Kind of along the same lines as ejection. With rollover, you have the momentary force, the momentum of the vehicle that's flipping around. Instead of just the patient's body weight, you've got the gross vehicle weight. In addition to that, you've got objects that are inside the vehicle that are not secured properly. 9 times out of 10, that become projectiles inside the vehicle. So, in addition to the initial impact and the rollover damage, you're going to have secondary, tertiary impacts, secondary to loose objects there. Of course, it goes without saying, high-speed vehicle collisions, the greater the speed, the greater amount of force accompanied by mass. So when you have a collision at a high rate of speed, vehicles tend to disintegrate, especially with the newer body styles. Crumple zones, there's just not enough vehicle to transfer the amount of energy. 12 inches or more intrusion into the passenger compartment. If a passenger vehicle sustains enough force to have a foot or better of intrusion into the passenger compartment, you're looking at a significant amount that it actually would penetrate through the frame and the infrastructure of the vehicle and intrude into the vehicle itself to make contact with the patient. So you want to take that in consideration, especially in relation to where the patient is sitting in the vehicle. Across from the side of impact, if say you're driving a vehicle on the driver's side, seated on the driver's side, and you take an impact to the passenger side, there's a good amount of force that's transferred there, not directly related to where that patient would be sitting if they were impacted on the side of the impact. So if you had enough impact on the passenger side, you would have extensive injuries compared to the opposite side. You have a pedestrian or bicyclist that's struck by a vehicle. That goes without saying. It's kind of like David and Goliath, but Goliath hits a lot harder. When you have a pedestrian or bicyclist struck, they don't have the crumple zones or airbags or seat belts or anything of that nature to secure and have any kind of safety features. So they're normally extensively injured. Motorcycle crashes are greater than 20 miles per hour, especially if the rider leaves the motorcycle. As a motorcycle rider myself, if I go to lay the bike down, my first instinct is to actually kick away from the motorcycle, usually because I'm wearing leather. I'm able to get away from the bike. You have a really high rate of injury and mortality if you try to hang on to the motorcycle while it's going down. But a lot of guys, if the impact is greater than 20 miles an hour and they are actually ejected from the bike, you have potential to strike multiple objects. You actually, in a lot of cases, will go airborne. But or penetrating trauma resulting in an altered mental status is really a significant one. If it hits you hard enough that it changes the way you perceive reality, it's significant. You can also, not only from the impact, have the damage to the head, but also take into consideration what's connected to your head, the spinal column. So you could actually have herniation of discs, you could have spinal trauma in addition to your head injury. Vehicle rollover, as we talked about, a lot of people drive around with their arms, legs, hands hanging out windows. It's to be expected. You'd have significant trauma with an MVC with rollover. Also take into consideration for a significant mechanism of injury, any penetrating injury to the head, neck, torso, or extremity above the knee and elbow. So what we're looking at there is, everywhere that you've got heavy skeleton, such as your skull, your rib cage, looking into your abdomen, where you have the pelvic girdle, and also your long bones. So if you have long bone fractures, those can actually be serious. You do have arteries that run close to those long bones. If they become fractured and splintered ends end up serrating an artery, you can actually bleed to death from a broken arm or a broken leg. Blast injuries from an explosion. A lot of people think about this in the terms of, like a hand grenade going off or an IED. Really and truly, the blast wave, the heat, thermal transfer, conventional explosives, is the amount that's being able to put into a significant blast for like an IED or things like that. Unless it's a just huge object that they're trying to make explode, the explosive potential for that is actually pretty low. The blast power, you're going to end up with more of a pressure injury than you would an incendiary injury. So you would expect to see more blast wave injuries than you would burns. Seatbelt injuries, see it pretty regular when somebody's not wearing their lap belt like they should. Instead of over their hips, they end up putting it over their abdomen. Sudden stop, the belt ends up becoming a constricting band and an unstoppable force, and it actually constricts over the abdomen and causes bruising and injures the internal organs. Also, we have to take into consideration collisions in which seatbelts are not worn, even if the airbags have deployed. I transported a patient several years ago that stated she didn't want to wear her seatbelt because she was against them, and besides, she had a safety feature, she had airbags in her vehicle. Well, it doesn't matter. I explained to her, it doesn't matter if you hit the steering wheel or you hit the airbag. You're still going to do it at 75 miles an hour like you did today. So, I mean, even with that being said, we're not wearing a seatbelt. You know, airbags and seatbelts should be used in conjunction with each other at all times. And if you don't have that cooperation between seatbelts and airbags, what you're going to end up seeing is the same type of impact that you would if they didn't have a seatbelt or airbag. The fact of the matter remains, you still hit an object at 75 miles an hour unrestrained, and it has potential to not only injure you further. You got to think an airbag deploys at around 210 miles per hour. So, I mean, you're getting hit, number one, by an airbag going 210 miles an hour while you crash into it at 75 miles an hour. Impact alone can end up breaking your neck, breaking your face, arm, leg, whatever you got between the airbag and you. Any impact causing deformity to the steering wheel is especially traumatic and a significant MOI due to the fact that the portion of your steering wheel, depending on how it's positioned in the vehicle, your chest takes a lot of that impact when you're not wearing your seatbelt. So if you hit a steering wheel hard enough to bend it, which is made out of steel, by the way, if you hit a seatbelt, or excuse me, hit a steering wheel not wearing your seatbelt with your chest hard enough to bend it, I'm going to start looking for blunt force trauma to the chest, and some of the complications arise from the cardiac tamponade, tension pneumothorax, hemothorax, all kinds of things like that, major bleeding internally, things that you have to look out for, especially in a trauma patient. And all this talk of MVC brings up, of course, the subject of prolonged extrication. You may have a somewhat stable patient, but they require a lengthy extrication, possibly have a leg that's strapped around a steering wheel or a brake pedal, thing of that nature, where something has to be cut or surgically amputated where you have to get them out. Conditions can change varied on time, so that's one consideration you have to take into effect when you're considering your transport priority and also your treatment protocols. By my standards, this is actually a pretty tame picture of intrusion into a vehicle that appears to be a rear end impact with the hood, from what I can tell, looking to the forward portion of the vehicle appears to be unaffected other than the airbag deployment, but the rear portion of the vehicle appears to sustain a significant impact. Without knowing the exact model make of the car, I would estimate that at probably 16 to 18 inches. 18 inches into any site on the vehicle should also be considered for a significant MOI. We'll take a look at some significant MOIs and special considerations for infants and children. Kids are shorter, so a good rule of thumb is 3 times the height on any patient that you have. So, I mean, 18 to 20 feet, that would be about right for an adult. 15 for a female sometimes. If you look at children, any fall greater than 10 feet or 2 to 3 times the height of the child is a significant fall. Also, bicycle collisions. Most of your bicycle traffic is going to be actually children, especially in neighborhoods. A lot of times that we see bicycle collisions is actually in neighborhoods. So that's one of the things that is kind of unique to the pediatric population. Pedestrian or occupant in a vehicle collision at a medium speed. When I say medium speed in regards to MOIs, I would say, your speed limits like on your county roads, in some of your residential neighborhoods where it's 35 to 45 miles per hour. Those are your medium speeds to where I would consider, possibility of significant MOI for children. And also, if the child is unrestrained in a vehicle collision, that is definitely a cause for concern. The head in proportion to adults on children is actually a lot larger. So their necks aren't, fully developed yet as far as being able to hold that head up. You can have a significant spinal injury from a medium impact, especially if the child is unrestrained. So while we're doing the rapid secondary assessment, we want to continue spinal motion restriction and maintain self-restriction or inline spinal stabilization until we can get that patient on a backboard stretcher. While one EMT performs a rapid secondary assessment, another EMT or assistant should continue to hold the head and neck in a neutral inline position and have the patient self-restrict until a cervical collar is applied. The patient then can be placed on a backboard and strapped in place and a head immobilization device applied, or the patient secured on a stretcher depending on the local protocol. You also want to consider requesting ALS. Some trauma patients may benefit from ALS at the scene or en route to ED. Airway trauma, included airway, or any indication that air from an injured lung is trapped in the chest cavity, causing the uninjured lung and the heart to be compressed, from a tension pneumothorax, may be the reason so that you got, your symptoms going on with your patient. So you would definitely want to call ALS or a unit that has the capability to do that. Always, always, always reconsider your transport decision. Look for evidence of critical injury or your patient's condition to deteriorate. Throughout the exam, keep in mind the possibility immediate transport. You always want to have that in the back of your mind. Do I need to upgrade? Do I need to do anything to expedite the transport of this patient? Always be reassessing and monitoring airway, breathing, and circulation. And while we're talking about reassessment, we'll also talk about reassessing the mental status. We want to get a repeat AVPU score, make sure they're oriented to time, place, and person, and event if possible, and also consider the Glasgow-Coma scale score. The Glasgow-Coma scale score can either improve or deteriorate depending on what your patient's baseline was initially. If your patient's unresponsive or deteriorating mental status, use the AVPU method. And if your patient's alert, you can assess the level of orientation by asking about time, place, person, self. Some examples are, do you know what year, month, and day it is? Can you tell me where you are right now? Who is this person with you? What is your name? Document everything precisely, everything that the patient tells you, or if they don't tell you, if they can't give you any information. Pertinent negatives are good for your documentation. It also gives your other emergency personnel that may be taking over care, it gives them criteria to use later to figure out whether the patient's mental status has improved or deteriorated. The Glasgow-Coma scale is used to rank the patient's level of consciousness by giving it a numeric score ranging from 3 to 15. The scoring tool is used with emergency medical services in mind to identify trends of improvement or deterioration in the mental status of your patient. The Glasgow-Coma score is widely accepted, is reproducible, and can be reported and recorded as evidence of the mental status trending. If you have a GCS of 8 or less, that can indicate a severe alteration in brain function. And while a GCS score of 8 or less, indicates the severe alteration in brain function, looking at a GCS score of 13 or less is an indication for limited on-scene time, less than 10 minutes, and for you to transport that patient rapidly to an appropriate facility. I'll give you a moment here to take a look at the categories. Classifications are going to be eye-opening, verbal response, and motor. So we're looking at eye-opening. You have a score of 4, 3, 2, or 1. Verbal response, you can have a score of 5, 4, 3, 2, or 1. And looking at the motor response, you can have a score of 6, 5, 4, 3, 2, or 1. Here's a version of the Pediatric Glasgow-Coma scale. I'll let you look at it for just a few seconds. If you have a patient that has a pattern of responsiveness followed by a loss of responsiveness, you really need to keep a close eye on these patients if they have a change in Glasgow Coma score and then return back to lucidity. Alright, when you perform a rapid secondary assessment, we are trying to identify signs and symptoms of potentially life-threatening injuries. So, we're going to use our senses to see what we can find out about this patient. Inspect, basically that's just a fancy term for look. We're looking for deformities, contusions, which is a common medical term for bruises, abrasions, punctures, penetrating wounds, burns, lacerations, swelling, unusual chest wall movements, angulated extremities, bleeding, discoloration, open wounds, and significant bleeding. When we palpate, we want to feel. So we're feeling for tenderness, deformities, swelling, masses, muscle spasms, skin temperature, and pulsations. When palpating for tenderness, pain on palpation in the unresponsive patient, watch the patient's face. They can grimace. When they grimace, that's usually a good indication they're experiencing pain. This gives you a good indication that there's an underlying injury without the patient being able to tell you verbally. Auscultate, listen with a stethoscope for presence and the quality of breath sounds. Listen for sucking wounds, gurgling, stridor, and crepitation. Crepitation is just a grating sound heard when broken bones rub together, or a crackling sound caused by air under the skin. Use your sense of smell to detect any unusual odors on a patient's breath, body, or clothing, such as alcohol, feces, or urine. All right, moving on, we're going to look at some common signs of trauma. I'm not a doctor, but I'm going to say that's broke. Looks to be definitely a dislocation, possible fracture. We can't say it's a definite fracture because we don't have x-ray vision in the back of the ambulance, but we have a definite protrusion. Looks to be a possible closed fracture or dislocation of the ankle to the medial side there. Here's a good example of contusions. Patient has contusions bilaterally under both eyes. Very good indication that you have bleeding underneath the skin, busted blood vessels, and looks like the formation of hematoma there underneath the right eye. These are abrasions. Abrasions are one of the more common injuries that you see with a vehicle operator or vehicle passenger ejected from a vehicle upon impact with pavement. This is the result, especially if the patient is still moving. There's a pretty good case of road rash there. Looks like the patient may have landed on their back and slid for several feet, causing the abrasions. Punctures, penetrations. This looks to be some type of abdominal trauma, unknown etiology. You can see at the mid-sternal position and also beneath the umbilicus that looks to be some kind of gel. That's probably ultrasound gel where they're looking for bleeding inside the abdomen and inside the thorax to ascertain the extent of the injury in the case that this patient is going to require exploratory surgery. Here's an example of partial thickness burns characterized by redness, swelling, and formation of blisters. It's a good example of the fluid shift as well, where the body is flooding the affected site with fluid, trying to cool the affected tissues down. Swelling or edema, this is noted there to the patient's right hand, it appears. He's also got some redness there. Could be secondary to trauma from impact with the hand, more than likely some type of allergy, in my opinion. An example of a laceration here. Laceration to the neck, as we talked about before, laceration or penetrating trauma to the neck can be severe due to the abundance of large vessels located between the head and the chest. So not only do you have a large venous vessel, you also have a extremely large arterial vessel there, being your jugular and carotid respectively. You could develop actually a pulmonary embolism through an open wound in the neck. So you especially want to take care with these type patients. Momentarily going back to swelling, specifically swelling of the abdomen. We want to watch for signs of swelling or distension in the trauma patient. Abdomen can be distended from air, fluid, or blood. If the abdomen appears to be distended, we need to be looking for signs of shock and poor perfusion. It takes a lot of blood to be lost in the abdomen before it starts to distend. So it's very easy to get behind the 8 ball when you're working with a patient with internal bleeding. Rapid secondary assessment is performed in a systematic sequence to make sure that all the major body areas are inspected and palpated. We're going to start with the head. Critical findings include trauma with altered mental status, unequal or unresponsive pupils. However, if a patient has unequal pupils but is alert and oriented, the unequal pupils are probably not from a head injury. We're looking for also cerebrospinal fluid in the ears or nose, blood, secretions, vomitus, teeth, bones, or debris in the mouth. Next, we're going to assess the neck. Some of our critical findings there would be JVD, or tracheal deviation, or tugging during respiration. We also want to apply a cervical collar at this point if we suspect there's any spinal injury. If applied prior to your arrival, don't take it off. Just make sure it's vented to where you can see the trachea and the JVD if present, and also a window to the C-spine. If the patient has neck veins that are flat in a supine position, it may indicate a decreased blood volume from bleeding. If the neck veins are engorged more than 2/3 the distance from the base of the neck to the angle of the jaw, they're considered what we call distended. We have a serious injury to the chest, lungs, or heart. So this is, a sign and symptom that you would see just prior to your assessment of the chest. Also, looking at the trachea, if it's shifted to one side, it's a very late indication with a significant amount of air trapped in the pleural space of the chest cavity. This can result in severe lung or chest injury. The trachea will deviate away from the injured side. So if the trachea is shifting towards the left, your injury will actually be on the right. Okay, moving down from the neck, we're going to look at the chest. Some of our critical findings. Open wounds to the chest, you're allowing air to go into the chest. That's a problem. You can end up collapsing your lung. Paradoxical movement, we've got, air or broken ribs that could potentially end up puncturing a lung if they haven't already. Absent or decreased breath sounds, that's just a sign that we have possibly a collapsed lung. And poor chest wall movement. Poor chest wall movement could be a result of broken ribs. The patient's not able to take a deep breath, so they decrease the tidal volume by not expanding their lungs as much and end up becoming hypoxic. If you really think about it, there's a lot of major stuff in the chest that, if injured, can result in a very sick and critical patient. Moving down to the abdomen, some of our critical findings we're looking for: severe abdominal pain, tenderness on palpation, any discoloration or rigidity, distension, and any organs that are on the outside that should be on the inside. For any critical findings, we need to go ahead and initiate rapid transport. Just as soon as we recognize it, go ahead and get that patient treatment initiated and get transport underway. Let's get our airway established and begin positive pressure ventilation at 10 to 12 breaths a minute. If the respiratory rate or tidal volume is inadequate, and let's make sure we got some high flow O2 going. For an evisceration, don't try to replace the organs. Rinse them with sterile water or saline and put a wet sterile dressing and cover them with a very large occlusive dressing over the top of the wet one. We need to get this patient transported rapidly. They're high priority. Make sure we get that airway established and provide supportive ventilations if required. Moving down from the abdomen, we're going to assess the pelvis. Critical findings there: any pain without palpation, or tenderness or instability on palpation. Of course, as with every other critical finding, these are high priority transports. You need to get them ventilatory support if required and initiate them getting to a definitive care facility as soon as possible. You can stabilize the pelvis and splint with a commercial or an improvised device. Let's make sure that we check all the distal pulses and all the extremities. We want to make sure in the lower extremities we're checking the dorsalis pedis pulse on the top of the foot. Another distal pulse that can be assessed in lower extremities is the posterior tibial pulse. If the patient can obey commands, ask the patient to wiggle his toes and squeeze your fingers. In a responsive patient, touch a finger on one hand and ask the patient to identify which finger you're touching. Then pinch the hand and ask the patient to identify the extremity with pain. Again, with any critical findings, apply direct pressure to the wound. Apply pressure dressings. If not controlled with direct pressure, apply a tourniquet. We want to provide rapid transport and administer oxygen for these patients. Fractured femurs, apply a traction split if it is a mid-shaft femur fracture. If it's closer to the knee or closer to the hip, we're not applying a traction splint, only mid-shaft. Extremities are also able to be tourniqueted. You could actually place a tourniquet on a leg or an arm. If you've got profuse bleeding coming, from an extremity and it's not in a junction where the extremity meets the torso, you can apply a tourniquet. Make sure you apply it high enough that we don't have to worry about applying a second one. If bleeding still persists after you apply the initial tourniquet, you can apply a second tourniquet just above the initially placed tourniquet. Moving on to the posterior of the body, critical findings, we have an open wound to posterior thorax or an open wound with spurting or steady blood loss. We want to occlude the wound immediately with a gloved hand and then with a non-porous dressing or occlusive dressing taped on 3 sides. These patients are high priority, so rapid transport again. Also consider an ALS intercept. Get that airway established, positive pressure ventilation at respiratory rate, or tidal volume is inadequate, and make sure they get supplemental high flow O2. Aggressive positive pressure ventilation may worsen a lung injury, so make sure that you don't give them more than they need. For hemorrhaging, apply direct pressure to the wound, apply pressure dressing if possible. Treat them for hypoperfusion, just as always. Now, after we've done our rapid trauma assessment, we're trying to wrap things up and get a good set of vital signs. We want to make sure that we get a breathing rate, pulse, skin, what the condition, color, temperature is, pupillary response, blood pressure, and pulse oximetry. When we're talking about breathing, we want to assess the rate, tidal volume, and quality. Determine the quality of breathing is normal, shallow, labored, deep, or noisy. While checking the pulse, we want to assess the radial pulse in the adult and child patient, while in the infant less than 1 year of age, we're going to go to the brachial pulse. If the radial pulse is not present, let's go to the carotid pulse. If there is a carotid pulse but no radial pulse, or if the radial pulse is weak and rapid, the patient is likely to be suffering from shock. Looking at the skin, it's assessed to determine the perfusion status of the patient. We're inspecting for pale or cyanotic nail beds and pale skin, oral mucosa, and conjunctiva. Feel the skin with the back of your hand for the temperature and condition. Pale, cool, clammy skin is a strong indication of poor tissue perfusion. Assess for capillary refill. Delayed cap refill may indicate poor tissue perfusion and shock. Quickly assess pupils for size and reactivity by shining a light to the patient's eyes. Come in from the side, don't go on directly. If you come in from the side, you're less likely to make the patient jerk their head. Poor perfusion can cause pupils to dilate and respond sluggishly to light, so this sign may be considered along with other indicators of shock. While we're checking the blood pressure, try your best to auscultate one. Determine the systolic and diastolic pressure. 2 signs of serious blood loss and shock are narrow pulse pressure and hypotension. There's some instances you will not be able to auscultate a blood pressure, as we discussed earlier in the lecture. Do the best you can to get an auscultated blood pressure if possible. If not, a palpated one will suffice. Pulse oximetry can be applied to determine if the patient's oxygenating adequately or not. Any SpO2 reading less than 94% should heighten your suspicion that the patient is going into shock. Y'all must also look for other evidence and a cause for the hypoxia. Of course, when you're looking at your vital signs, you need to know your baseline limits and your normal ranges. But here's some of the critical findings you can have. SpO2 is 94% of your patients, doesn't have an adequate respiratory rate or tidal volume. Carotid pulse is absent, and any child or any patient greater than 1 year old, or absent brachial pulse in a child that's less than 1 year old. Unequal pupils, cool, clammy skin, weak, rapid pulses, decreasing systolic BP, narrow pulse pressure, delayed capillary refill. All these things are critical criteria that upgrade a patient status to emergent and rapid transport, high priority. And here's one of the unsung heroes of the vital sign world, the blood glucose test. Any patient that has an altered mental status, you should check a blood glucose on for the simple fact of somebody may be diabetic and not have been diagnosed with it. Denial is one of the biggest obstacles at one establishing primary care physician, and patients are in denial about their condition so they don't make an appointment with their physician, which results in an undiagnosed medical history. Sometimes this can be the cause root problem of what your MOI was and a treatable and reversible symptom in your patient. Of course, as always, with unstable patients and trauma patients, if you have a high index of suspicion that this patient is a high priority rapid transport patient, we want to repeat vital signs every 5 minutes. This is another mnemonic that we use, especially in trauma patients. A lot of times we're unable to get great information, but this is some of the best information that we can get, and one of the bare minimums I would like to have when I go in with a patient. It's called a sample history. It's a mnemonic SAMPLE. The S is for signs and symptoms, A is for allergies, M's medications, P's pertinent past medical history, L last oral intake, and E events leading to the illness or injury. Of course, your most reliable source of information 9 times out of 10 is going to be your patient. If your patient is unresponsive, do your best to ask a bystander or a family member. Some of the examples of questions you can ask are, do you hurt anywhere? What symptoms are you experiencing? Like I said, if the patient's unresponsive, ask the bystanders if they complained of any pain or any other symptoms before they lost consciousness. You can ask the patient, do you have any allergies? Are you allergic to any medicines? Are you currently taking any medicines? Have you had any recent illnesses? Have you been seeing a doctor for any condition? Quickly figure out if the medical history from the patient or if the patient's unresponsive from a family member. You can ask them, when did you last eat or drink anything? How did the incident happen? Figure out if the trauma patient can recall any of the events prior to. That can also give you an indication of any type of retrograde amnesia or any kind of head injury. And next, we want to prepare the patient for transport. Ideally, this should be performed simultaneously with rapid secondary assessment. We want to provide spine motion restriction if it's indicated. Your on-scene time should be limited to 10 minutes or less. Sometimes that is doable, others it is not. That should be your goal from the time your boots hit the ground to the time you're shutting the doors on your rig should be 10 minutes. Also utilize the guidelines for field triage of injured patients. And it was published by Centers for Disease Control. They developed it, and it's a protocol. It provides objective criteria and recommendations for rapid transport to a trauma center. Remember, our ultimate goal is prompt transport and getting them to a definitive facility for surgical intervention. That is the key to survival of the critically injured patient. To ensure the best chance of survival in certain situations, trauma patient must be transported to the appropriate trauma center. So sometimes instead of going to the closest hospital, you may end up having to call for the appropriate resource to get that patient to a higher level facility. Here's just a list for some indications that a 10-minute or less on-scene time in rapid transport would be prudent. Airway occlusion, they have a difficult airway to maintain. Respiratory rates less than 10 or greater than 29 a minute. Tidal volumes inadequate. Patient is showing signs of hypoxia. SpO2 is less than 94. Any respiratory distress, failure, or arrest. They have an open wound to the chest or a flail chest segment. You suspect a pneumothorax, uncontrolled external hemorrhage, suspected internal hemorrhage. Any signs or symptoms of shock. Significant external blood loss with controlled hemorrhage. GCS of 13 or less. Altered mental status. Seizure activity, sensory or motor deficit, any penetrating trauma to the head, neck, anterior, posterior chest, abdomen, and above the elbow or knee, amputation of an extremity proximal to the finger, trauma in a patient with significant medical history, previous history of MI, COPD, congestive heart failure, if they're greater than 55 years of age, experiencing hypothermia, burns, and if they have a history of being pregnant. Once that patient's on the stretcher, transport should not be delayed. Any critical findings are present and the trauma patient ends up being unstable, like I said, your on-scene time should be limited to 10 minutes or less. Providing emergency care, your life-threatening injuries and conditions must be appropriately managed as found at the scene prior to the transport. So anything that you found that was life-threatening in your primary assessment and in your follow-up rapid trauma assessment should be managed before you leave with that patient. During transport, life threats are reassessed, so you want to double check and make sure that what you did to correct those life threats is still in effect and still working, and then you want to further evaluate that patient and provide care as necessary. We need to set priorities for the management of critical injuries and conditions. If you have a patient that's bleeding out from a mid-shaft femur fracture, that ankle fracture can wait. I've seen somebody splint somebody to death, as I mentioned. So you need to make your priorities in conjunction with the findings that that are revealed during your primary and rapid trauma assessment. And it should only take you to probably 2.5 minutes to do a rapid trauma assessment. For the secondary assessment, it goes from head to toe, vital signs, and getting a history. For this kind of patient, they're likely going to be critical. Head-to-toe assessment should identify immediately life-threatening injuries and conditions and other less severe injuries or problems the patient may have. So it's head-to-toe, but it's very, very fast. Trauma score criteria. Be familiar with the trauma scoring system in your region. The major components of the trauma score are respiratory rate, systolic blood pressure, and the Glasgow Coma Scale score. Now, the trauma score and the Glasgow Coma Scale score are not the same thing. You want to report and document the findings of the revised trauma score. This information is very useful to the receiving facility for purposes of reassessment. Now, in the stable trauma patient, we want to perform a modified secondary assessment where the mechanism of injury does not lead you to suspect additional injuries or problems, and you just basically assess just the specific localized side of the injury. We're going to get vital signs and history and perform a rapid secondary assessment if it's indicated. The patient's unresponsive. I want to conduct a rapid secondary assessment, obtain baseline vital signs, make sure the patient's positioned, obtain a sample history, and then transport the patient. Secondary assessment for the unresponsive medical patient is similar to the secondary assessment for a trauma patient with a significant mechanism of injury because in both instances, you need to first examine the whole body for information that the patient cannot tell you. In the responsive patient, we're looking to assess complaints plus signs and symptoms, obtain a sample history, conduct a modified secondary assessment focused on the chief complaint, assess vital signs, and make transport decisions. A responsive medical patient is one who not only responds to your questions and commands, but also responds appropriately. If the patient responds but not appropriately, consider the patient's responses to be unreliable and conduct a rapid secondary assessment. Our rapid secondary assessment of the medical patient, when we assess the head, if we find anything critical such as unequal pupils with altered mental status or facial droop, those are critical and it makes this patient high priority. If you look inside the mucosa, inside the mouth, the oral mucosa, and find that they're pale, that may indicate that the medical patient has been losing blood over a long period of time, such as a GI bleed. Moving down as we did on the previous secondary assessment, we're going to assess the neck. Critical findings, of course, would be jugular vein distension or tracheal tugging. As with any other patient with respiratory insufficiency, we want to provide positive pressure ventilation at 10 to 12 a minute. If your respiratory rate is less than the normal rate and tidal volume is inadequate, also administer supplemental oxygen if you suspect hypoxia. Moving down to the chest, critical findings include retractions, accessory muscle use, diminished breath sounds, crackles, wheezing. Manage your airway as you should. If the respiratory rate is insufficient, consider CPAP with a patient with adequate breathing but decreased tidal volume if they're able to maintain their own airway. For wheezing, make sure you get that airway established, positive pressure ventilation. Patient medications may be administered such as epinephrine or a metered dose inhaler. Consider CPAP. as well. Moving down to the abdomen, some of your critical findings that you'll look for are severe abdominal pain, tenderness on palpation, discoloration, rigidity, distension. Provide rapid transport upon recognition for any of these. Make sure we got the airway established, respiratory support if needed, and oxygen if indicated. Moving down to the pelvis, we're looking for lower quadrant abdomen or pelvic pain, tenderness on palpation, female in childbearing years with history of missed periods or vaginal bleeding. Should also send up an alarm. Rapid transport any of these, of course, as well with any recognition of these critical criteria. Assessing the extremities, we want to note any excessive peripheral edema, assess for pulses, motor function, and sensation. Also look for any medical identification jewelry or tags around the wrist or ankle. Excessive edema could indicate congestive heart failure, fluid overload, or a clot blocking a vein in that extremity, DVT. In a medical patient who complains of a sudden onset of shortness of breath, let's make sure that we look at the lower extremities and check them for pain, redness, or swelling to one of the calves. That patient may also have pain in the calf when pulling his foot upward towards his head. Could be an indication of a blood clot in a deep vein of the lower leg that has broken off and traveled to the lungs, resulting in a pulmonary thrombosis or a pulmonary embolism. You want to assess the posterior body, palpate the back for discoloration, edema, and tenderness. Assess for edema to the sacral region, to the sacral spine. You're looking for sacral edema in patients who are bedridden and have their legs level with the heart. Excess fluid in patients who are mostly in a seated position and dangle their legs or who are moving about will collect in the hands, ankles, and feet rather than in the sacral region. Of course, with these patients, we want to assess their vital signs, do a blood glucose test for patients with automental status. It could be something simple to fix, such as hypoglycemia. Make sure the patient's positioned appropriately to avoid the potential for aspiration. We want to place the patient in a left lateral recumbent position for transport if they're not alert or disoriented or unresponsive. Again, we want to get a sample history on these patients, looking for following indicators: shortness of breath, chest pain or other pain, severe headache, lightheadedness, dizziness, faintness, severe itching, abdominal or lumbar pain. History is a quick method for obtaining limited but extremely important information. The patient's got an altered mental status. A more detailed history that goes beyond this is not pursued. Let's provide our emergency care and make our transport decision. Considering that these patients are disoriented or unresponsive, that kind of puts them at the critical threshold, high priority. So we're going to reassess vital signs every 5 minutes. We're going to provide emergency care following the secondary assessment based on our signs, symptoms, and history that we gathered. Routine use of high concentration oxygen for every patient is no longer recommended. A lot of old school guys do that, and it is actually found that high concentrations of oxygen are actually harmful in patients that don't require it. Altered mental status in a medical patient is a critical finding. There could be several causes for it. Transport should be prompt. However, life-threatening injuries and conditions must be managed at the scene prior to transport. For the patient who's responsive and alert and oriented, let's assess the patient complaints using the mnemonic OPQRST. Complete the history, perform a modified secondary assessment, assess the vital signs, provide emergency care, and make the transport decision. During transport, reassess the airway, breathing, and pulses. Take the vital signs every 5 minutes in the critical or unstable patient and every 15 minutes in the non-critical or stable patient. On every patient, assess the effectiveness of the interventions that you did. So if you perform an intervention to this patient, you want to make sure that your intervention worked. So go back and check your vital signs and reassess the patient. And just like you would give a patient that, is hypoxic, if they have, SpO2 reading of 89%, after we put them on oxygen, let's reevaluate that and see if they have improved to at least 94%. You should get a pattern, kind of a rhythm that you would go through to where you assess, find something, intervene, and then reassess to find out if what you did worked. Purposes of reassessment determine change in the patient's condition and assess the effectiveness of emergency care. Showing trend. It's often most performed in the ambulance until care of the patient is transferred to the hospital personnel. If you have a delay in transport, reassessment begins on the scene, such as like a prolonged extrication or inability to access the patient, things of that nature. Reassessment is ensuring that you are basically barking up the right tree with the assessment findings that you've got and the direction of treatment that you started in. And think about what are some potential consequences of failing to reassess patients, what they could be. You will get into a rhythm and develop a process, assess the patient, intervene, and then reassess. Be sure that you can detect any change in what the condition of that patient is. You can identify missed injuries or conditions, and this enables you to adjust your emergency care if necessary. When we're trying to detect the change in the patient's condition, when we're reassessing, rapid deterioration is commonly due to continued blood loss, airway compromise, patients not breathing adequately or oxygenating adequately, the patient's got poor perfusion, or they possibly have a brain injury. Another reason that we reassess, we want to identify anything that we missed. So to identify any missed injuries or conditions, especially those that are life-threatening, that's huge. Reassessment gives you that opportunity to look for injuries that you might have missed on the primary and secondary survey once the patient's in a more stable and favorable environment, which is most likely the patient compartment of the ambulance. And, of course, the other reason to adjust your emergency care if necessary, if you're headed down the wrong pig trail, it gives you a chance to pull back out, get onto the main road, and figure out which direction you're going. Some of the steps of the reassessment, basically you're going to repeat the primary assessment and reassess and record your vital signs. Repeat secondary assessment for other complaints, injuries, or a change in the chief complaint. Check your interventions, make sure that they're working, and note trends in the patient's condition, whether they be good or bad. These are also going to be recorded every 5 minutes for unstable patients and with critical injuries, and every 15 minutes in the stable patient. We want to reassess mental status, look at changes in speech pattern, or if their answers are appropriate, assess their ability to obey commands, and also get a reassessment on the Glasgow-Coma scale. We're going to reassess the airway, reassess breathing, and reassess oxygenation. Going back to the mental status reassessment, a patient with a head injury can continue to talk to you, but his speech pattern may become garbled and his responses become inappropriate. You should also assess the patient's ability to obey commands appropriately and repeat the GCS and obtain another score and compare it to the initial and others. If the patient's talking to you is not in distress, assume the airway is patent. In the unresponsive patient, make sure you open the mouth and look inside for evidence of blood, secretions, or vomitus. Loss of a gag or cough reflex may require the insertion of an airway adjunct. Look, listen, and feel for adequate breathing. If the patient's breathing is inadequate because of poor quality or rate, begin positive pressure ventilation with supplemental O2. Increasing resistance during ventilation can mean that the airway is not being maintained effectively, that the stomach is filling with air and pushing up on the diaphragm, or that the patient with a chest injury may be developing a tension pneumothorax. Immediately reassess the airway and breath sounds. When you reassess oxygenation, apply oxygen to the patient who shows signs or symptoms of hypoxia, hypoxemia, respiratory distress, poor perfusion, or heart failure, or any patient who complains of dyspnea. The patient has a decrease in the SpO2 reading of less than 94%. We want to reassess the pulse, and record the pulse rate and quality. Reassess bleeding, reassess the skin and capillary refill, looking for skin color changes and feel for changes in temperature and condition, and also reestablish our patient priorities. When you evaluate the pulse rate in relationship to the initial findings and look at the injuries or medical condition. Any major bleeding, we want to check that site for any blood seeping through the dressing and intervention you applied. May indicate the need to control the bleeding through additional direct pressure. If the bleeding is severe and cannot be controlled with direct pressure, we want to go ahead and apply a tourniquet. As far as the reassessing the skin and cap refill, improvements in oxygenation typically improve the color of the skin. So poor oxygenation from an airway or breathing compromise will cause the skin to become cyanotic or blue-gray. If the patient's condition is noted, it may be necessary to reconsider your emergency care and transport decision. So you're constantly reevaluating your patient's classification as stable or unstable, or their transport priority. To complete the reassessment, we want to reassess and record our vital signs and repeat components of the secondary assessment for other complaints, recheck our interventions, and note trends in our patient's condition. Reassess the breathing rate and quality, pulse rate and quality, perfusion status, pupils, blood pressure, and SpO2. Record those vital signs and the time they were taken. That way you have a basis of what point in the encounter that they were taken at. If the patient begins to complain of a symptom that was not initially identified or there's a change in the original symptom, complete the relevant components of the secondary assessment. Ask yourself the following questions when considering the adequacy of intervention. Have the patient's vital signs improved or deteriorated? Is the patient's airway still patent? Is the oxygen device and leader flows adequate? Is oxygen connected and flowing to the bag valve mask device? Has the patient's SpO2 improved with oxygen, or should I consider positive pressure ventilation? Is the patient's chest rising and falling adequately with the ventilations? Are the chest compressions producing pulses? Is the rate and depth of compression adequate? Has a cardiac arrest patient whose heartbeat has been restored lapsed into arrest again? Is the AED indicating that a shock is needed or not needed? These are all questions that you should continue to ask yourself back and forth throughout this entire transfer. Is what I'm doing working, basically? Am I barking up the right tree? Am I getting this patient the treatment that they need? Am I getting them to the place that they need to be at? Am I getting them quickly enough? So to summarize, patient assessment provides the foundation for patient care decisions. This is the keystone for your direction of treatment and also for the treatments that you would provide. Patient assessment process has multiple components, starting with scene size up, primary assessment, secondary assessment, and reassessment. And the purpose of your primary assessment is to find any life-threatening conditions and intervene immediately. Secondary assessment is performed. You're looking for problems in addition to those that may be identified in the primary assessment. But we're not moving to the secondary until we finish primary, right? So the approach to the secondary assessment is based on whether the problem is trauma or medical and on the patient's condition. Unstable trauma patients and unresponsive medical patients receive a rapid secondary assessment, but stable trauma patients and responsive medical patients receive a modified secondary assessment. Reassessment is performed on all patients for 3 reasons. 1, want to detect the changes in condition. 2, identify those missed injuries or conditions that we might have missed on the secondary assessment. And 3, adjust our emergency care as needed. Steps of reassessment are repeat the primary assessment, reassess the vital signs, repeat the secondary assessment, check interventions, and note trends in the patient's condition. That concludes the lecture. Thank you very much for sitting through this 2 hours. I appreciate your time. Good luck to you.